Hello, I'm Bob Falcone, CEO of the Columbus Medical Association. Today we have the CMOs from the three adult systems in Central Ohio with us. Dr. Nick Kriatsolis from Mount Carmel Health Systems, Dr. Bruce Vanderhoff from Ohio Health, and Dr. Annie Thomas from The Ohio State University. The governor on Monday released some guidelines for getting us back to the business of taking care of patients as hospitals. Annie, you've been part of that process. Would you just give us a brief summary?
Sure. Thanks, Bob. It's great to be here today again. If you think back to where we were in March, when we were looking at a potential bump in surge in patients, nationally, the American College of Surgeons, the Surgeon General, all sorts of organizations came out with recommendations to limit inpatient and outpatient procedures and surgeries, really for three main reasons. One was to facilitate the implementation of social distancing. So the ability to not have people coalescing in healthcare environments is the same as not having them come together in other types of areas in the community. But really, it was about the conservation of PPE, making sure that we had enough protective equipment for surgery patients, as well as conserving our inpatient bed capacity and all the things that go along with that, with staffing and so forth. So as we've looked to unravel that from mid-March and to step back into the business of doing more healthcare services, really it was looking at where are we with social distancing, and I think all of our facilities are doing things in terms of screening visitors and people wearing masks in clinics, people wearing masks in the hospital, that I think will help us as we restart things to make sure there is better social distance and infection control. Similarly, the PPE supply chain is not perfect, it's not optimal, but it's better than it was. So from that perspective, if those two reasons are relatively stable, we still need to probably protect some inpatient bed capacity because we may still have some sort of a surge as other parts of society start to reopen. The thinking of the team from the state was, let's go ahead and allow things to restart for outpatient surgeries, outpatient testing, diagnostic testing, imaging, things that don't require an overnight stay in the hospital or an inpatient admission. So the focus, since even the guidelines went in March, has been if you need a procedure to protect your life, limb, preservation of an organ, prevent the risk of metastasis or spread of cancer, as well as prevent the risk of progression to severe symptoms. Those things could always be done since March. But what this will allow us to do starting tomorrow is anything up to something that requires an inpatient stay. The language does talk about medically necessary things as well, so I do think they want to put a hold yet on kind of cosmetic and other procedures, even if they're in the outpatient setting. But the final order actually is still, I haven't seen it yet. Maybe it's come out today. But that's kind of where we're at. I think the expectation will be to wait a period of time to look at the number of cases in the community, number of hospitalizations, based on other businesses starting to reopen before we would go back to full court press with all sorts of inpatient surgeries and other things. So.
And the three of you with your teams talk almost every day, sometimes twice a day, to make sure that when we reopen it's coordinated and we maintain bed capacity and we maintain critical care capacity. Nick, you and I were talking earlier that our hospitals are half full, our EDs are half full. Where have all the MIs gone? Where have all the strokes gone? Have we stopped having those disease processes?
No, the diseases are still out there, Bob. Yeah, and the concern that I think all of us have is where are the chronic diseases? And we've kicked these diseases, quote unquote, down the road. When are they going to start coming to fruition where patients need admissions? We have seen an increased surge of these chronic diseases in all of our institutions. And just more so in the last week, we've seen a huge uptick in chronic diseases. So our concern really is about our community and our population and how we're going to manage these chronic diseases going forward. The other big concern that I've had, and I've discussed with our team and with my colleagues at our other hospitals, is we have kicked the primary care visits down the road over the last 2 months. So patients with these chronic diseases are not being evaluated or not having their disease optimized. And that's a bigger concern, that we need to get these patients into their offices. And that's where the advent of telemedicine is really going to play a big part in this. There was an article in Becker's Hospital where the CMS administrator mentioned that sort of the cat's out of the bag now, that payments for telemedicine will not go away and probably will increase over the next several weeks, months, and years as we start to see a change or a re-evolution of healthcare.
And I think we all think that's a good thing.
Yeah,
Telemedicine's
absolutely.
been
Absolutely.
very effective.
Yeah.
Bruce, you've got a large, diverse system, diverse geography, diverse capability. How is Ohio Health approaching tomorrow when we're supposedly going to reopen everything?
I'll tell you, this has really been an opportunity for us to build on some of the physician engagement infrastructure that has been evolving over the course of the past several years, and to really work with our medical staff to deal with an awful lot that's been unknown. I think all of our systems at the very start of this pandemic hitting our community were confronted with an historic degree of the unknown with which we had to cope. And we've been able to work with our clinical guidance councils and our surgery advisory committee to grapple with how do we solve a whole bunch of problems that didn't have out-of-the-book solutions that needed to be developed. More recently, we've been looking at how do we go toward a safe reopening? How do we move back towards safely providing care for surgical patients? How do we, along the way, ensure the community that the hospitals are the safest place for their patients to receive care, not a place to be avoided? And so together, our medical staffs across the whole geography that we serve, largely through the lens of our clinical guidance councils, have helped us to develop what I feel are really good answers to a number of those questions. So today, if you look at our hospitals, we're a very different place than we were as recently as 6 weeks ago. We have masks being widely utilized. We have very different protocols in place for our physicians who are caring for patients who might have a respiratory illness or who might require an aerosolizing procedure. We're also thinking very differently about the care of the patient who is in the surgical or the procedural arena. And they've helped us identify not only good practices and protocols to put into place, but they've been very mindful of the challenges that are a part of a global supply chain. They've recognized that some innovations are needed to cope with that global supply chain. The work that we piloted with Battelle, and that now all of our systems, I believe, are embracing and engaging with.
That's the re-sterilization of masks.
The re-sterilization of N95 masks was introduced by one of our physicians who said, I think this might be a possibility. I've got a spouse who's working at Battelle. Let's see what could happen here. So that was a physician innovation. Other physician innovations where they identified a group of entrepreneurs here in Ohio who were developing an intubation box that created one more barrier of separation and yet allowed for the quick and easy implementation of an additional barrier that is protecting the staff and yet is assuring that good patient care can continue to go forward. So it's really been wonderful to see, and it's been an opportunity for our medical staffs to provide leadership in an historic time.
So when you say intubation box, you don't mean an intubation kit, you mean a box that fits around the
box.
It is an actual,
clear-
that's
clear
right,
box.
it's a plexiglass box. It's really very simple, that is able to be brought in, placed over top of the patient's head. The intubating physician can still see everything that they need. The patient can see through it. And yet, as they reach into that intubation box, they have an additional layer of separation, and they are simply using the smoke evacuator that's normally used in surgery. That's stuck in there, and is helping to create a negative airway space that's in addition to the room having a negative airway space.
What an elegant solution to a complicated problem. I want to re-emphasize one thing you said that I think was really important, and that is that hospitals are the safest place to be right now. And I'm really distressed that patients have been avoiding care because their hospitals are in fact safe. They've got a much better chance of dying of their disease process than they do of COVID in the hospital. Andy, are your operating rooms full for tomorrow?
We are kicking back in mostly on Monday. I think when the announcement came out Monday, we were ramping up. I think a couple people are going to start tomorrow, but for the most part, we'll be doing things at the Sports Medicine Institute, Eye and Ear Institute. Those are our ambulatory facilities. And then we certainly still have outpatient surgeries, I think, as all of you do at our hospital sites as well. So those will be kicking in more full speed on Monday. But our goal is actually to try and get caught up as much as possible on things that were delayed in the outpatient setting so that by the time inpatient surgeries do restart, that we won't have a big backlog of outpatient surgeries still to do.
Nick, how about you? Are
Yeah.
you filling up?
We're filling up. We're doing the same as what Andy mentioned. We want to do it in a methodical way, in a safe manner, because it's been so slow for several weeks. So we're gearing up just like everyone else is. And we want to make sure that we're bringing the right patients into the operating room, as we discussed. And we want to make sure we're following the orders of the governor and bringing those patients that really are urgent or emergent. We're still sticking to that criteria, or if it's affected the patient's ability to function.
When you talk about some of the things that you're looking at, what do you mean by the right patient?
Well, the right patient really has to fall under the definition described by the governor. And we want to make sure we're following those criteria. We just don't want to do plastic surgeries that really are using up our PPEs. Remember, the virus is not going away anytime soon. And there could be resurgence of the virus over the next several weeks and months, even a year, until we can obviously get herd immunity or some kind of immunization over the next several months to a year. So we want to be cautious about how we're using our PPE, and we're selecting the right patients for surgery, even in this arena. But we also have to be cognizant, I mentioned this before, we've kicked a lot of these chronic diseases that needed surgery a month or two ago. Patients are struggling with their disease processes. We need to get them in and get them cared for. And again, do it in a very safe and methodical manner.
Bruce, same thing?
Same thing. I've been incredibly proud of the way that our physicians have responded now to the governor creating the opportunity for more surgeries to happen. They have really led the charge in saying, we need to do this safely. There's tremendous pent-up demand and interest, certainly for their own practices, and yet they have said, as we head into next week, let's do this in a very thoughtful way. Let's do this in a stepwise way. Let's make sure that at each step, as we're expanding the volume of surgery that's being performed, it's being done safely. And so I think that if the governor were aware of just how safety conscious the medical community is as they look at something that really has been an existential threat to many other practices, I think he'd be immensely proud.
I agree.
So speaking of safety, Andy, how are you guys with PPE?
We're doing
And how are
okay.
we with PPE?
We're doing okay. I think that better than we were a month ago. I think when you see not just the region, the state, our country, but countries all over the world essentially looking at the same supply chain. And then, of course, the area initially hardest hit by the virus was where a lot of those supplies come from. I think the innovations that have happened in Ohio with manufacturers getting into the business of making PPE are incredible. Bruce has already talked about the innovations with conserving and recycling PPE. So I feel like we're better. Although just last week, I don't know what happened, gowns went on allocation for us for the first time through this whole process, which kind of came out of the blue. But the same material that they make gowns out of, they make other things out of too. So I think we're better than we were. I think if you look down our supply chain charts, there's a lot of green and yellow. There's not as much red as there was, a month ago. But the highest number of patients that our zone has had in the inpatient setting was just this week. So it's not like we're on the downslope yet. I think the exponential growth has stopped and we've kind of plateaued, as many have talked about. But I think as we reopen society, I think we're all holding our breath to make sure that we have the supplies we need.
And the governor made some recommendations on PPE, as you all know, and they range from a mask if you're not in direct way of a patient with COVID or potential COVID patient to full PPE, face mask, a gown, probably a hat and shoe covers if you're in the way of aerosolized content. We have fortunately not had that much COVID in our hospitals, which surprises me. I think it surprises all of us. Right now, as of this morning, we had 302 patients in our region, which is Zone 2 and regions Central, Southeastern, and Southeast Central Ohio. We had 302 COVID patients, 120 in the ICU. That doesn't begin to even broach our capacity. So as long as it sounds like we can keep up with PPE, our physical spaces, I don't think it'll be a problem in the near term.
Well, at the same time, though, I think most of us run in routine operations 98% capacity during the week for our main Columbus hospitals. If you have more patients, COVID patients in your hospital than you have ICU beds on a routine basis. I think we've all flexed up to create new capacity. So I personally would like to see the numbers going down a little bit more before we ramp back up to 90+% inpatient.
But one of the other things that we have an opportunity to do and that we've learned through this time period is there has been historically care that has landed in our hospitals that really didn't need to be there. A lot of it was in the category of observation care. And I think that that's an important component to how we respond to this going forward. As we're thinking about being able to now run a marathon and continue to provide care for patients with COVID-19 for some time into the future, and think about being able to do a good job of being very, very busy and caring for the chronic medical conditions and surgical needs of the community. We really think that a big part of that sustainability, that solution, is less a matter of expecting that curve to drop off quickly, because I actually think that curve has a much flatter trajectory than we had originally imagined, and therefore is going to be sustained over a window of time. What we need to do to ensure we can do all three of those things is avoid a resurgence of some of the care that really can be better delivered through telemedicine, through better outpatient home follow-up, et cetera. And we've been doing that through the last several weeks, largely by taking advantage of hospital-at-home type care, taking advantage of virtual care capabilities that frankly are allowing us to do a much better job in partnership with primary care docs, in partnership with specialists at caring for those patients outside the hospital. And I think that's going to be a big key to moving things forward.
Let's switch gears just a bit and talk about testing. I know we have done a wonderful job of getting test kits and reagent, and at present we're in pretty good shape. But I think there's a fair amount of confusion in the community about some of these tests marketed directly to patients. The two that I want to just briefly touch on, that is the test for the presence of the virus, the antigen test, and then we'll talk a little bit about the antibody test. So whoever wants to start.
Well, let me start with the antigen test because it's really important. As you said, it is the test that tells us that a person right now is sick with COVID-19. And one of the developments that people, if they haven't heard about already, are going to be hearing about is the announcement that Kroger, in partnership with a lab, is offering a direct-to-consumer access to that test. And how should we think about that? And I think that our health systems together, along with Columbus Public Health, are viewing that as that's one more opportunity, that's an adjunct to the work that we're already doing. The fact is that the way that they are able to bring that test forward, which includes having people collect their own sample, is probably not able to provide the level of collection sensitivity that we would look for in a hospital setting, but that's not an all bad thing. If we're looking at helping people identify COVID-19 as the source of their symptoms, that is a plus, not a detractor from what we're doing. But rest assured, when patients are coming to our facilities, our medical community can be confident that the tests that we're going to run are run with sensitivity and specificity top of mind, and we're assuring that the tests we're running have the highest sensitivity and specificity.
And Nick, I assume you, like the others, are doing standard nasopharyngeal swabs for your tests.
Correct, correct.
Yeah.
And what you're talking about at Kroger is
They're doing an anterior nasal
Yeah.
sample, and we're doing either nasopharyngeal or oropharyngeal. There is one platform that has very high specificity with the oropharyngeal collection, but in either case, it's not an anterior nasal collection.
Yeah, the key is the viral load.
Yes,
Are you
that's
really
right.
getting enough virus when you swab the anterior nasal areas, or are you getting a better viral load as you progress posteriorly in the nasal pharyngeal space? So we need to be cognizant of what tests are out there and are they really that helpful to the patients and the community.
Thanks. So Andy, when we're talking about viral load, is that how the reagents test for the virus in some quantitative fashion? You've got this much virus is positive,
Correct.
you got this much it's negative?
The sensitivity, it depends on which assay you're using, but the sensitivity can go down to how many copies of the virus there are per cc to generate whether it's a positive test or not. So the standard PCR tests where you extract the RNA and so forth are a little bit different than the Abbott box. That's the rapid test, but they all work on the same basic principle where they're looking for actual copies of the virus.
So it's very important that we have an accurate collection,
Yes.
or as accurate as we can make it.
Yes.
What about the antibody tests? I'm getting more calls than I know what to do with from physicians that are saying, hey, there's all these antibody tests out there. Can I get my family tested?
Well, a lot of the tests that are out now, so the FDA really eased some of the normal requirements for tests because of the scenario we're in and let some things flood the market that I think all of us have concerns about. Some of them are not even FDA approved at all. A couple are FDA approved. These are oftentimes rapid tests that you can do with a finger prick. They're almost more similar to a pregnancy test in terms of just saying antibody yes, antibody no. They don't get into the amount of antibody that you have or whether those antibodies are actually what are called neutralizing antibodies that actually can kill the virus, or if they just speak to the presence of the antibodies. The big difference there being whether you're immune or not is determined by what type of antibodies you have as well as how many. So I think they are what they are. My worry is people over extrapolate what a positive means. I don't know.
I think you're right. And one of the other questions is we haven't answered the question of durable immunity yet. I think we all believe.
What do you mean by durable
So
immunity?
just going back to our medical school days, there are basically two big buckets. I'm talking to the trauma surgeon here.
I didn't go to medical school.
But there are two big buckets. There's more the humoral or short-term immunity that we developed to things like the common cold. Doesn't last. It helps us for a little window of time, but it's not going to protect us for next year's season. And then there are a whole variety of more durable immunities that will last for a period of years. Some of them are really long-lasting, like what we developed to measles, and some of them are maybe a few years. We're pretty optimistic that this virus, which in the family of coronaviruses, is a lot more like its cousins SARS-1, this is SARS-CoV-2, and the MERS coronavirus. It's acting a lot more in terms of the kind of illness it creates, et cetera, like those viruses than its cousins that cause more common cold type symptomatology. So there is optimism that it will, but Andy spoke very well to knowing that, and let's assume that's the case, you still have to make sure your antibody test is checking for the right antibodies that are produced in response to the virus. And neutralizing antibodies are the ones that you want to be going after, and we're still learning which of the antibodies are going to be representative of that population of antibodies. So what I would say to our medical community is, your health systems are on this. We are looking very actively at which are the best antibody tests for us to be using clinically. The antibody tests are going to be telling us about the recovered folks. They're going to be telling us about herd immunity. They may eventually be telling us about who's protected from the virus. But right now, the key issue for the medical community is those acute viral tests. Yeah. Who is sick right now?
Well, I do think all of us are aware of either patients we've taken care of, or we hear stories from our colleagues about folks that I thought they definitely had the flu in January or February, and they tested negative. That's so odd. I mean, I think it's made all of us think this might have been around in our community long before early mid-March when we started having cases in Ohio. And we may find out that there were more people that had this than we thought. And that's really where the antibody test will be helpful.
And you are about done developing a test to try,
Yeah,
right?
we're probably, we've come a long way. Initially when they were working on it, it was doing false positives for things like the Lyme disease antibody and other things. So it's really trying to perfect getting it to be both sensitive and specific, so you're not ruling in things that really aren't truly the right antibodies. I would say we're probably within a week to 2 weeks of going probably more widespread in trialing it, getting in touch with patients who we know had a positive PCR and having them come in, test their blood. We are using a version of the test that we've designed for our convalescent plasma program, so that I think all of us are doing some version of that, working with our blood bank partners and using convalescent plasma. But I think before we're going to say to every primary care doc, yep, go ahead and just order this, we probably are a couple weeks away from that yet.
And Bruce, I think you're in the same situation.
We are. Yeah.
But not ready for prime time yet.
That's right.
Nick, are you doing any of your own?
No,
any of your tests?
Actually, we're as the testing starts to evolve, we'll chime on as well. But right now, we're following what is currently out there with our testing for it. And as we're going to start seeing, companies are becoming very innovative. We're going to start seeing what Bruce and Andy have talked about in how we gauge immunity. What's the concentration of that immunoglobulin in your blood? Is it qualitative or quantitative? What are we testing, and how are we going to test these patients? And as this evolves more and more, and as we learn more and more, you're going to be surprised at how fast we're going to have testing for the community in general. But
so I think the message to our physicians, our primary care physicians who are probably on the front line, is it's not ready yet.
It's not ready yet.
Yeah, I would be really careful with some of the things that are available off the shelf.
I agree.
No,
and
I'd be
using those in your
cautious.
practice. You could be giving patients bad advice.
Yep.
Yeah.
I agree. I agree.
So we've been through a lot in the last 6 weeks, and we're going to be through more, I'm pretty sure. A year from now, how will all this change our healthcare systems?
So, I can probably take some of that on, and I know my peers have been in the community much longer, but from my vantage point, I'm starting to see an evolution of healthcare in the telemedicine arena, and consolidation of procedures and the way we do business on a daily basis. How our primary care offices are seeing their patients, and do they need to see them immediately? Do they need to see them via telemedicine? I'm also starting to see in the horizon how healthcare in general is going to change. We didn't have enough hospital beds, we talked about prior to this. Now, where are we with our hospital beds in general? Do we need more? Do we need less? And financially, how are all of these institutions around Ohio and around the country going to be able to survive the decrease in census that we had over the last 2 months? And we're relying on these surgeries that we do on a daily basis that went away for the last 6 weeks, 8 weeks. And how is the government going to be able to help support some of these smaller hospitals as their financial well-being is at stake? So it's going to be an evolution, as I've talked about, on how we're going to approach medicine in the future. It's not going to look the same. It's not going to look the same. and we're going to train our doctors a little differently. And I think our younger doctors are, in my opinion, I think our younger doctors are, I think, ready for this. They're the techies. They like technology, and they're going to evolve with newer technologies to help their patients as we move forward. So I think it's an exciting time in some way. We can't just keep doing the same thing over and over again. And this is making us change the way we're doing things.
Yeah, it makes complete sense. I hope we never get to the point where we don't touch a patient.
No, that can't happen. Let me stress that very clearly. That cannot happen. We as physicians have to see our patients. And there has to be a way where we get patients in to see their physicians. That is a very important aspect of their health care. Yeah.
In terms of the way things have changed, I have a phrase that I used the other day. It just kind of came out of my brain. So I feel like we've done 6 months worth of management in 6 weeks because of the number of decisions, the pace of decisions, the cadence of decisions. And actually, I think just from our type of role in the organization, and you've had a similar role, obviously, when you were at Grant or at the VA, the nimbleness that our organizations have shown over the past 6-8 weeks has been really impressive to see. And I think we also owe it to our patients, to our staff, to our providers to continue to be that nimble moving forward and not be in the situation where it's, 3 quarters from now, we'll maybe think about doing that thing we thought was a good idea 9 months ago. It's going to be much more rapid in terms of change, I think, for all of us as well moving forward.
Yeah, and I think another thing that it's done is it's emphasized something that we always knew but never really lived, and that is that there are really 2 clinical principles that we've been following in response to COVID-19 that are going to stay with us. One is, social distancing is an important thing to remember anytime you're dealing with communicable disease. And we've dealt with communicable disease every single winter, the flu. And yet we've never done a good job of thinking about the importance of staying away from other people when we're sick, avoiding touching our mouth and nose, and then touching other things, and then the reverse of that. And the masking and the 6-foot distance, that's all really been a set of tools that are really designed to remind us about that. But the other piece, and you see people not only in healthcare, but thankfully we're beginning to see the general public now really pay attention to hand hygiene. And I think the hand hygiene lessons, as well as we'll either call it social distancing or masking type behaviors, I think they're going to be with us for the foreseeable future.
Well, it's been very interesting, and I hope that the people watching realize how much cooperation there's been between our healthcare systems to tackle this problem. It's absolutely phenomenal, and it's been going on for over 20 years, so this is not anything new, and it's really very exciting. So I want to thank Nick, Bruce, Andy for joining us. Till next time, this is Bob Falcone from the CMA.